Welcome. I'm Dr. Catherine Ruddy from Mayo Clinic in Rochester, Minnesota, and I'd like to welcome you to this spotlight session entitled Life After Breast Cancer, Cardiac Health, Fertility Preservation, and Returning to Life. We have three excellent discussants today who will each be discussing a set of posters, which are at the back of the room. Our first discussant is Dr. Carmen Bergom from the Washington University School of Medicine. Dr. Bergom.
Thank you so much for the opportunity to speak to you today. We have some great abstracts in this session, and so I'm honored to be a part of it. So today I'm going to be talking about the issue of survivorship with respect to cardiac toxicity, so the state of the heart after breast cancer treatments. These are my disclosures. So I'm going to be discussing three abstracts, three of the posters back there today, and they all, as I mentioned, have to do with cardiac toxicity. And as many of you know, therapy-induced cardiac dysfunction is a large clinical problem. It's estimated there are more than 17 million cancer survivors in the US. And as far as breast cancer patients, there's more than 3.5 million US breast cancer survivors, and this number is growing. And many of these patients receive systemic therapy and or radiation therapy that can cause long-term toxicities, including cardiac toxicity. And the way in which these toxicities manifest range from valvular heart disease, coronary artery disease, abnormal conduction, pericardial disease, microvascular dysfunction, or other problems stemming from myocardial fibrosis. So it's a wide range of problems, and there are a lot of different aspects of cardiotoxicity that we're realizing are more important for us to pay attention to in cardiac survivor or in breast cancer survivors. And to put this into perspective, as shown here, these are leading causes of death, and cancer, of course, is one of the main causes of death, but it's eclipsed only by cardiovascular disease. And so many of our patients have cardiovascular disease at diagnosis. After their cancer diagnosis, many of them also will develop cardiovascular disease, so it's very important for us to take into account cardiac health after their treatments are completed, and even during their treatments. So today we're going to be discussing these three abstracts. And the first one is looking at cardioprotective strategies in breast cancer patients receiving chemotherapy. And this is looking at the impact of postoperative breast radiation in the phase 3 SAFE trial. And the presenter of this, Dr. Miatini, is in Italy. It's very late there this evening, and will be available for questions after, so please keep in mind questions for the end of the presentation. So some background on this poster. As you know, cardioprotective strategies to prevent myocardial dysfunction have been evaluated in many trials, but there really is no optimal treatment that's agreed upon at this point. An echocardiogram is considered the standard cardiac imaging evaluation during and after systemic therapy, and the remodeling that precedes ventricular dysfunction and a reduction in global longitudinal strain can predict early cardiotoxic events in a number of trials. Angiotensin-converting enzymes, or ACE inhibitors, and beta blockers can prevent cardiac remodeling and reduce mortality in patients with cardiac dysfunction, and they have been proposed for use in the cardioprotective setting in oncology. The SAFE trial is a 4-arm randomized phase 3 double-blind placebo-controlled trial. And shown here on the right are the 4 arms of the trial. There's a placebo group, ACE inhibitor group, beta blocker group, and a group that received both beta blocker and ACE inhibitor. The objective of the trial is to determine whether pharmacologic cardioprevention could reduce subclinical heart dysfunction in the breast cancer patients treated with anthracycline-based chemotherapy. So the methods of this study, this was a subgroup analysis on the impact of postoperative breast radiation in a pre-specified interim analysis of the first 174 patients who completed cardiac assessment at 12 months, so the echocardiograms at 12 months. And the cardioprotective therapies were initiated at the start of chemotherapy and given for 1 year, or until the end of trastuzumab therapy in HER2-positive patients. The primary endpoint was any subclinical impairment or worsening greater than 10% in myocardial function and deformation measured with standard and 3-dimensional echocardiogram, and ventricular ejection fraction and global longitudinal strain. Univariate and multivariate analysis were performed, and the factors included were smoking, the treatment arm, right versus left-sided radiation, trastuzumab treatment, cycles of anthracycline, age, and BMI. And so the results demonstrated that, looking at the 3D left ventricular ejection fraction, they found that changes from baseline to the end of treatment were seen in the bisoprolol, the beta blocker containing arms, and there was a significant benefit in patients that didn't receive, in all patients, and patients that did not receive RT, and in patients receiving right-sided breast radiation. And there was also an effect in breast receiving left-sided radiation, but it was on the borderline of statistical significance, so not as significant. With respect to global longitudinal strain, shown in the panel here, the changes from baseline to the end of treatment, when they examined these, the beta blocker containing arms showed significant benefit in all patients, and in patients not receiving radiation therapy, and in patients receiving right-sided radiation therapy, while they did not see a benefit in patients receiving left-sided therapy, and that's shown over here in this panel. And when they looked at the differences in treatment, statistical differences, only the trial arm was associated with global longitudinal strain worsening. And so essentially what they saw is that in the placebo arm, there was worsening of global longitudinal strain compared to the other arms. So in conclusion, at the interim analysis, cardioprotective pharmacological strategies in patients affected by breast cancer receiving anthracycline-based chemotherapy were well tolerated, and they seemed to protect against cancer therapy-related left ventricular ejection fraction decline and heart remodeling. And the favorable effects seem to be reduced in patients, which is a hypothesis-generating finding, receiving postoperative left-sided breast radiation, which requires further examination. Perhaps the remodeling that occurs after radiation was not altered as much with the bisoprolol therapy. So, and they do note, however, that the only significant parameter related to global longitudinal strain and the worsening of ejection fraction was represented in the placebo arm of this trial, thus confirming a crucial role for cardioprotection in patients affected by breast cancer who receive anthracyclines. So the last two of the abstracts are actually from the same data, the Pathways Heart study. So the first one we're going to examine is looking at the risk of breast cancer therapies by body mass index. Dr. Greenlee is also available at the end of this presentation for questions. So, background on this study, many breast cancer therapies are cardiotoxic, as we've mentioned, but overweight and obesity are risk factors also for cardiovascular disease. There have been few studies examining whether BMI or body mass index modifies the effects of breast cancer treatment on cardiovascular risk. In this study, the authors examined whether cardiovascular risk by breast cancer therapy varied by the body mass index group, so normal weight, overweight, or obese patients at diagnosis, and this was done at Kaiser Permanente, Northern California registry. And so looking through their health records, they included females diagnosed with breast cancer from 2005 to 2013. These are the therapies that were examined, so chemotherapy, endocrine treatment, and radiation therapy, looking at all comers for radiation, and then left-sided only patients. And as far as cardiovascular outcomes, these were obtained from ICD-9 and 10 codes, and they examined ischemic heart disease, heart failure, and cardiomyopathy, and stroke. They performed Cox proportional hazards models to estimate relative risk of the cardiovascular events based on, for each therapy compared to those who did not receive that therapy or that treatment. And they excluded underweight women and those with missing BMI. So this study included over 13,000 breast cancer survivors. The mean age was 60, and the mean follow-up was 7 years. For ischemic heart disease, they found that in women with normal weight, the receipt of anthracyclines was associated with a 4 times relative risk of ischemic heart disease relative to women with normal weight and no receipt of anthracyclines. They didn't see any other risk associations associated with other therapies in this group for ischemic heart disease or in other BMI groups. For heart failure and cardiomyopathy, in normal weight, patients' receipt of anthracyclines, cyclophosphamide, or left-sided radiation was associated with higher risk, and then those are shown in these panels over here. In overweight women, anthracyclines was associated with higher risk, but not the other therapies, and there were no risk associations for women who received trastuzumab, taxanes, endocrine therapy, or all comers for radiation. And they also found no risk associations for women who are obese. And for stroke in normal weight individuals, the receipt of taxanes, cyclophosphamide, and left-sided radiation were associated with higher relative risk, shown over here. And for women with obesity, anthracyclines, taxanes, cyclophosphamide were associated with lower relative risk. And no risk associations, once again, were found for trastuzumab and endocrine therapy or oral radiation. And no risk associations were found in women who are overweight. So the conclusion of the study is that certain chemotherapeutic drugs and left-sided radiation might confer higher risk of cardiovascular disease for breast cancer survivors with normal weight, and certain chemotherapy drugs may lower stroke risk for breast cancer survivors with obesity. A lack of associations for increased risk of heart failure was noted among obese patients, which could be due to the obesity paradox, also observed in other obese populations. And the analyses are planned to examine whether different dosage and duration of the therapies across the BMI groups contribute to these risk associations. So with the caveat of this study not being retrospective in nature, these are some interesting hypothesis-generating findings. So the last abstract is from the Pathways Heart Study once again, and this is looking at the development of cardiometabolic risk factors following endocrine therapy. And so, as you know, endocrine therapy can be associated with cardiovascular disease in breast cancer survivors and might be associated with developing cardiometabolic risk factors, including diabetes, dyslipidemia, and hypertension. Tamoxifen has missed estrogenic and anti-estrogenic activity, while aromatase inhibitors deplete endogenous estrogen. Many studies compare tamoxifen to aromatase inhibitor users, making it challenging to understand independent impacts. In this study, the risk of incident cardiometabolic risk factors in tamoxifen and AI users versus women who did not undergo endocrine therapy was examined in the Kaiser Permanente Northern California patient population by querying health records. Very similar criteria, or the same criteria to the prior study as far as inclusion. And for this study, they looked at identification of the cardiometabolic measures using a number of different ways, which are shown here, including diagnostic codes and other information such as hospitalizations and prescriptions for certain things such as hyperlipidemia. Once again, multivariable Cox proportional hazards models were used, and they were adjusted for baseline factors listed here, and women with the risk factors at baseline were excluded from this analysis. And this resulted in almost 15,000 breast cancer survivors that were examined, and of these, 25% were premenopausal at baseline. Mean age was 61, with once again a 7-year mean follow-up. And there were 3,700 premenopausal women, and of these, more than a quarter used tamoxifen, and over half didn't use any endocrine therapy. So the results of this study demonstrated neither tamoxifen nor aromatase inhibitors was associated with the risk of developing diabetes, dyslipidemia, or hypertension relative to those who didn't get the treatments. And of 11,000 postmenopausal women, 6% used tamoxifen, about half used AIs, and 45% did not use endocrine therapy. And what they found in these women is that neither tamoxifen or AI was associated with the risk of developing diabetes or hypertension. But with respect to dyslipidemia, the AI users had a higher risk, while tamoxifen users had a lower risk relative to women who did not use endocrine therapy. And this is just shown here. So in premenopausal women, there was no statistical associations between the development of these cardiometabolic risk factors. But in postmenopausal women, we see the higher risk in AI users and tamoxifen users having a lower risk of dyslipidemia. So in conclusion, they conclude that AI use may increase the risk and tamoxifen may lower the risk of incident dyslipidemia in postmenopausal breast cancer survivors. And so we had these 3 abstracts that were gave us very interesting data and add to our knowledge of ways in which to improve treatment, surveillance, and cardioprotective therapies to optimize cardiac health in breast cancer survivors, and I think have generated some nice hypotheses to be examined in future studies. So with that, we wanted to allow some time for questions. We have about 10 minutes, to my understanding, so if anyone has any questions, we do have the presenters virtually available. Thank you.